and bone marrow study. So what is aplastic anemia? Aplastic anemia is characterized by marrow hypoplasia with failure to form blood cells of all three lineages, resulting in peripheral cytopenia. Means RBC will decrease, WBC will decrease, and platelet will decrease. All three lineages will decrease. And along with marrow, means bone marrow, hypoplasia will occur. Now, classification of aplastic anemia. It is of two types, inherited and acquired. Inherited, Fanconi anemia, dyskeratosis congenita, Schwarzman-Diamond syndrome, Diamond-Blackfan anemia, congenital megakaryocytic thrombocytopenia. Then acquired cause. Most common cause is idiopathic aplastic anemia. Then aplastic anemia associated with other hematological disorder like PNH, MBBS, and LGL. Then secondary cause, ionizing radiation, drugs and chemicals, infections, among the infections, hepatitis, Epstein-Barr virus infection, parvo-19, influenza, HIV infection. Then immune-mediated, idiosyncratic disorders, miscellaneous, means autoimmune disease. Now there are some drugs which cause aplastic anemia. Cytotoxic drug used in cancer chemotherapy, cyclophosphamide, chlorambucil, methotrexate, 5-fluorouracil, vincristine, vinblastine. Then drugs causing idiosyncratic marrow injury. Chloramphenicol, nitrofurantoin, indomethacin, diclofenac, gold salt, carbonic anhydrase inhibitors like acetazolamide. So these are the drugs causing aplastic anemia. And now chemicals associated with aplastic anemia. Benzene, arsenic, alcohol. Now the pathology of aplastic anemia. There is a primary defect in or damage to the stem cell compartment or marrow microenvironment. Then CD34 cells are substantially reduced. Then cytotoxic T lymphocytes produce gamma-interferon and TNF, which affect the mitotic cycle and induce fast-mediated apoptosis. Now, aplastic anemia is considered as a T-cell mediated destruction of stem cell. So the main pathology is, or pathogenesis is, due to apoptosis. Apoptosis is the main reason, that's why aplastic anemia is occurring. So, main thing is apoptosis. Now, aplastic anemia is considered as a T-cell mediated destruction of stem cell. Now, pathophysiology. In majority of the cases, aplastic anemia is an immune-mediated disease. T regulatory cells are diminished in aplastic anemia. Now it is known that there is overexpression of HLA-DR2 and polymorphism in cytokine genes. T cells get activated, increased production of IL-2 leads to polyclonal expansion of T cell which secrete IFN gamma, interferon gamma, and tumor necrosis factor alpha. So these are the two main mediators, interferon gamma and TNF-alpha. Then these interferon gamma and TNF-alpha affect the hematopoietic stem cells and progenitor cells and also through fast ligand and fast receptor. This fast ligand and fast receptor involved in apoptosis. That's why I am telling apoptosis is the main thing in this aplastic anemia. The stem cell undergo apoptosis and thus the stem cell diminish in the bone marrow. This is the main thing. Due to apoptosis, aplastic anemia is occurring. So you understand the pathophysiology. So basically, aplastic anemia is an immune-mediated disease. Basically, it is an immune-mediated disease. Now the clinical features. Clinical presentation of this patient is due to anemia, leukopenia, and thrombocytopenia. Clinical features are bleeding gums, paresy, menorrhagia, fever due to neutropenia, and severe infections. So these are the clinical features. Now the criteria for diagnosis of aplastic anemia. Progressive cytopenias and the marrow aplasia are the key diagnostic feature of aplastic anemia. So cytopenia is progressive type and the marrow aplasia. So not only progressive cytopenia, but also there is bone marrow aplasia or hypoplasia. These are the key diagnostic features of aplastic anemia. Diagnosis of severe aplastic anemia requires at least two of the following. Number one is granulocyte count less than 500 microliter. Number two is platelet count less than 20,000 per microliter. Number three is absolute reticulocyte count less than 1% or less than 40,000 per microliter. These are the 3 points. Among these 3, at least 2 should be fulfilled. Granulocyte count less than 500 per microliter, platelet count less than 20,000 per microliter, absolute reticulocyte count less than 1%. In addition, not only this, bone marrow biopsy must contain less than 25% of the normal cellularity at that age. Then, it is severe aplastic anemia, criteria of severe aplastic anemia. Then very severe aplastic anemia. Fulfillment of criteria of SAA with granulocyte count less than 200 per microliter. It was less than 500 per microliter. It was severe. Now it is very severe. So, granulocyte count less than 200 per microliter. Now, third is non-severe aplastic anemia. Patients who do not fulfill criteria for SAA and have neutrophils more than 0.5 into 10 to the power 9 per liter or platelet more than 20,000 per liter. Now, blood findings. Hemoglobin, absolute neutrophil count and platelet count are all decreased. Reticulocyte count less than 1%. PBS, pancytopenia with normocytic, normochromic or macrocytic red cells. These are the 3 blood findings. So you can hear it is a PBS finding, peripheral blood film. These are normocytic, normochromic red cells, and you can see there is marked thrombocytopenia and neutropenia. Only one lymphocyte is seen. Only one lymphocyte and there is no other cell. Now the bone marrow findings. Hematopoietic precursors got progressively diminished with concomitant increase in fat. In bone marrow, fat space will increase. BMA may be dry cap or diluted marrow. Bone marrow biopsy, BMA means bone marrow aspiration. BMB is bone marrow biopsy. Bone marrow biopsy is essential to assess the exact cellularity which is diminished. There may be focal cellular areas in the marrow which show lymphocytes, a few plasma cells, and mast cell. So in bone marrow, finding is lymphocyte, few plasma cell, and mast cell. And bone marrow aspiration, dry cap. Then myeloid and megakaryocytic precursors are markedly diminished. In the late stage, cellularity is markedly diminished and mainly fat is demonstrable in the marrow. Main thing is fat space. cellular space or cellularity will decrease, fat space will increase. Hemosiderin-laden macrophages can be easily made out in marrow aspirate and trephine sections. Now these are the pictures of bone marrow. You can here see the fat space. These are all fat space. So normally this much fat space should not increase. Normally cellular material will increase. But here you can see all are fat space. And here you can see the lymphocyte, plasma cell and mast cell. These are you can see the fat space. Now the management of aplastic anemia. Stem cell transplantation, immunosuppressive therapy, androgens, L-thrombopath, packed cell transfusions, and platelet transfusions. Now the bone marrow scarring. Bone marrow scarring means bone marrow aspiration and bone marrow biopsy, both. So bone marrow examination provides semi-quantitative and qualitative assessment of the state of hemopoiesis. Biopsy of bone marrow is an indispensable adjunct to the study of disease of blood. It may be the only way a correct diagnosis can be made. Because from peripheral blood, we sometimes cannot correctly diagnose. In that case, bone marrow aspiration or bone marrow biopsy helps us. This is the normal structure of bone. Cortex, outer part is cortex, inner part is medulla. Cortex, strong layer of compact bone, gives bone strength, made of lamellar bone, contains well-organized Haversian canals. Bone marrow, normal bone marrow, two types, red marrow, yellow marrow. Yellow marrow is composed of adipose tissue. Red bone marrow consists of 4% of total bone marrow. Total weight of the weight of total bone marrow 1600 to 3700 gram. In children, most bones contain hematopoietic cells. In adult, skull, sternum, scapula, ribs, pelvic bones, proximal ends of long bones. Here you can see hematopoietic cells, sinusoid, and stroma. It is a picture of bone marrow decalcified. Now the site, sternum, anterior iliac spine, posterior superior iliac spine, overlies a large marrow space, larger sample can be obtained. Upper end of tibia, children less than 1 year old. The most common site of bone marrow aspiration in adult is posterior superior iliac spine. In sternum, we never do. Why? Because below the sternum, behind the sternum, heart is there. So, most common space, most common site is posterior superior iliac spine. It is the safest place for bone marrow aspiration. These are the different types of needle. It is Lima sternal needle, Salah bone marrow aspiration needle, Waterfield, and modern Jamshidi needle. We commonly used Salah's needle or Klima's needle. These are the commonly used needle. So you can see the outer layer is skin, bone, and bone marrow. So the needle should reach in the bone marrow space. This is the posterior superior iliac spine. Now, aspiration and biopsy. Aspiration, better psychological detail, more range for cytochemical stains, flow cytometry, IC, ideal for cytogenetics, molecular genetics, but disadvantage is dry gap in fibrosis, like in aplastic anemia. It will dry gap. So in that case, we have to do biopsy, bone marrow biopsy. And yes, it is less painful. Now bone marrow biopsy. Biopsy, better topographical detail, cellularity, infiltration, less range, can be used for cytogenetics and molecular genetics, essential for diagnosis in dry gap. And yes, it is more painful. So, bone marrow aspiration and trephine biopsy. Aspiration, anticoagulant used for flow cytometry, cytogenetics, molecular study, heparin vial, flow cytometry, cytogenetics. EDTA vial used for molecular genetic study. And trephine biopsy, decalcification, tissue processing, sessions, HNE, special strain, ISC. If we do not calcify, then electron microscopy, bone disease, or osteopathy. You can see this is the normal cellularity, hypercellular, hypocellular. Now the indications for bone marrow aspiration. Indications, rectal disorder, megaloblastic anemia, pure rectal aplasia, pancytopenia, anemia unresponsiveness to therapy, then leukocyte disorder, subleukemic and aleukemic leukemias, acute leukemias, unexplained peripheral deficiency or excess of leukocytes, immature or morphologically atypical cells on a blood film, megakaryocyte and platelet disorders, unexplained thrombocytopenia or thrombocytosis, myeloproliferative neoplasms, myelodysplastic neoplasms, paraproteinemias, multiple myeloma, Waldenstrom macroglobulinemia. Then infections. To detect organisms and or their characteristic cellular or host response, unexplained fever, HIV infection, suspected lysosomal or other storage disease. Then iron stone assessment, metastasis, unexplained hepatomegaly and or splenomegaly, marrow harvesting for bone marrow transplantation. Now indications for bone marrow biopsy. To evaluate patients in whom an adequate bone marrow aspiration is not obtained, like in aplastic anemia. To accurately assess marrow cellularity, suspected focal lesions or marrow fibrosis, to study bone structure, marrow architecture or marrow vasculature, to diagnose aplastic anemia, hypoplastic MBBS, and hypoplastic acute leukemia. Then, investigations and prognostication of suspected myeloproliferative neoplasms, investigation and staging of suspected Hodgkin disease and NHL, diagnosis and follow-up of hairy cell leukemia, chronic lymphocytic leukemia, and other chronic lymphoproliferative disorders. Then, diagnosis and staging of suspected metastatic carcinoma, diagnosis and staging and follow-up of small round cell tumor of childhood, investigation of an unexplained leukoerythroblastic blood film, investigation of fever of unknown origin. Investigations of patients in whom multiple myeloma is suspected, investigation of suspected primary amyloidosis. So these are the indications and indications of bone marrow aspiration and bone marrow biopsy. Rectal disorder, leukocyte disorder, megakaryocyte and platelet disorder. These are the main infections, and there are a few indications of bone marrow biopsy. Now contraindication and complications of bone marrow aspiration and bone marrow biopsy. Contraindications of marrow procedures. A cardiac aspirate is absolutely contraindicated in patients with disease associated with marked osteoporosis and in young children. Coagulopathies, acquired or congenital. Bone marrow biopsy is contraindicated. Bone marrow aspiration should be deferred until essential. Isolated thrombocytopenia is not a contraindication to a carefully performed, technically sound procedure. Now the potential complications to a marrow procedures. Hemorrhage is the commonest critical adverse event. Hemorrhage. Then continued pain at procedure site and infection. Then perforation of thoracic structure in case of puncture of inner cavity of sternum. Patients administered general anesthesia or sedation carry the respective procedural and pharmacological risk. But usually bone marrow aspiration and bone marrow biopsy both we do under local anesthesia, not under general anesthesia. Now procedure. A written consent should be taken from patient. An appropriate clinical history should accompany the bone marrow as they relate to possible finding within the bone marrow as examination. It is useful to know relevant lab data such as iron studies, folate or vitamin B12 study, transfusion therapy, or history of chemotherapy. The physician's clinical impression should be included in the form. Linear sensitivity test should be done. Complications, hemorrhage, pain, infection, perforation of major vessels, risk of general anesthesia and sedation. Now, the interpretation. So, in low power, what we will see? Determine cellularity, bone marrow cellularity. Identify megakaryocyte. It is very important to identify megakaryocyte. If we see a megakaryocyte or megakaryocyte present in the bone marrow aspiration film, then only we can sure yes it came from bone marrow. Otherwise not. If there is no megakaryocyte in the bone marrow slide, then we will not sure. We are not sure whether it is come from bone marrow or not. Note morphology and maturation sequence. Look for clumps of abnormal cells, metastatic tumor, identify macrophages. But identify megakaryocyte is the most important in case of bone marrow aspiration. Now, higher power. Identify all stages of maturation of myeloid and erythroid cells. Determine the myeloid-erythroid ratio, AMI ratio. Perform differential count, erythroid, myeloid, lymphoid, plasma cell and others. Look for areas of bone marrow necrosis. Assess the iron content of the macrophages. Look for iron granules in erythroid cell in pulse scan. It is an erythroid island. These all are erythrocyte. Maturation sequence of RBC. Early pronormoblast, basophilic normoblast, polychromatophilic normoblast, early orthochromatic normoblast, reticulocyte, normal RBC. It is the maturation sequence of neutrophil. Myeloblast, promyelocyte, megamyelocyte, band cell neutrophils. Here you can see myeloblast, and these are the promyelocyte. It is a myelocyte. It is the megakaryocyte. These are the plasma cell. Eccentrically placed nucleus. Now there are bone marrow findings in few infections. In parvovirus infections, you can see giant proerythroblast. HIV, histoplasma, HIV cryptorchus. HIV changes, increased cellularity, increased fibrosis, and lymphoid aggregates. It is a granuloma, and these are the acid-fast bacilli, findings in tuberculosis. Now, this is the bone marrow reporting format, bone marrow aspiration reporting format. So, first, the identification points of the patient name, detail of patient, name of the physician, name of the requesting doctor, date, clinical history, and on the above there will be a short PBS finding. This is must. The PBS finding which I find in the peripheral blood film, it will present in the bone marrow aspiration form, reporting format. Like hemoglobin, TNC, DNC, platelet count, reticulocyte count, and peripheral blood smear finding. Now, the bone marrow reporting format starts from here. Bone marrow cellularity of particles and cell trails, nucleated differential cell count, myeloid erythroid ratio or M ratio, erythropoiesis, myelopoiesis, megakaryopoiesis, lymphocytes and plasma cells, other hematopoietic cells, macrophages, mast cells, abnormal cells like blast cell, metastatic deposit, iron stain, stromal alterations, other investigations like cytochemistry, flow cytometry. This is the reporting format. Now the reporting format of bone marrow biopsy. Length of bone marrow biopsy, accurate or not, marrow cellularity, erythropoiesis, myelopoiesis, lymphopoiesis, plasmapoiesis, megakaryopoiesis, bone marrow necrosis or gelatinous marrow transformation, then iron stores, bone architecture, reticulin stain, abnormal cell infiltration. So this is the format of bone marrow aspiration and this is the format of bone marrow biopsy. In bone marrow biopsy, we extra information we get bone marrow necrosis, gelatinous marrow transformation, and bone architecture, reticulin stain. These are the extra information we get from bone marrow biopsy. Okay?